Hi guys, very good evening to everybody. So it's time to discuss some important questions which have been asked in our exam earlier. My main focus would be to talk about those critical aspects which help you increase your strike rates. So let's focus on those important questions that I'll be discussing. And anyway, the topic that we're discussing is like the topics that I'll be discussing are critically important. I'll be discussing them over 2 days. That is, some session would be done today and some parts of the topics would be discussed tomorrow as well. The main focus would be to make it interactive. So I would like you to comment in the chat box as much as you can. I want you to check out your reflexes and practice them. Even if you're wrong, it really doesn't matter because this is a practice session. The objective of the session is to help you realize those high yield topics that are always coming in the paper. Give me a quick thumbs up with respect to whether the audio and the visual part is perfect, and I think we can get going with the core aspects that are required here. Okay. Quick answers quick answers would always be expected for the topic that is being discussed. And in the first one that I'm discussing at the moment before you, the question is with respect to like a lady who has undergone a delivery and she's having calf pain with asymmetry of legs. This is actually a recall question. Last winter, this question was asked. A lady after delivery is having calf pain and asymmetry of the legs, and then she's having this extensive breathing difficulty and saturation is dropping. Because the question is mentioning that she's having calf pain and at the same time she's also having asymmetry of the legs. So I can say that this patient is suffering from deep vein thrombosis, that is a DVT in the patient. And considering that there is a asymmetry of the legs, that gives more credibility to the word deep vein thrombosis because we get a Homan sign, and that Homan sign is ankle dorsiflexion will contribute to calf pain in a patient. Now the bad news is she's having breathing difficulty, so जो clot है वो टूट के it would have gone into the lungs of the patient. So the clinical diagnosis in this particular case is pulmonary thromboembolism. The key word is, the buzzword for this question that you need to pick up is the word sudden onset breathing difficulty. The buzzword for this question is sudden onset breathing difficulty in a patient or deep vein thrombosis. He may not write the word deep vein thrombosis as this happened in this question. It is just that he will talk about asymmetry and he says which of the following tests would be the first one to be checked in this first test to be evaluated in this patient. So I'm waiting for your answers here, guys. Just do a quick comment with respect to like what do you think would be the most appropriate first option for this question. The options are pretty straightforward ones, and because this is a repeat one, so that's why I'm asking what do you think is like the most appropriate one. When it comes to option number A, that is a chest X-ray, I think you would agree that it's a very non-specific test that would help us in diagnosis of this condition. So I'm ruling out option number A, chest X-ray. And then he says D-dimer assay. So D-dimer assay makes sense because that's going to be a screening test for this condition. CT angiography is the investigation of choice. So this is unlikely to be an answer because the question is saying the word first. And the moment you pick up the word first, you know that this is not going to be the answer. One is Doppler of the extremities. Doppler of extremities would help me determine the etiology. That is like what is the cause. But when it comes to identifying pulmonary thromboembolism, if he says what is the first test to be done, our answer would be given as D-dimer assay because that will increase the diagnostic yield. Or body में जब भी clots होते हैं, whenever you are having clot formation in the body, then the D-dimer assay values would always be elevated. The last time you guys would have written D-dimer essays, I'm very sure would be for those cases where, suppose COVID-19. In COVID-19, it was a hypercoagulable state, so we were like going ahead with the D-dimer assay. But in this case, like it is, very, I would say typical kind of a question that is to be remembered. Okay, fine. I think I missed out in between slightly, but then I think, yeah, that's what I'm trying to say. CT angiography is the investigational choice for this condition. It would be D-dimer assay to find out the etiology in this patient. In postpartum, would D-dimer be elevated? No, pregnancy is the hypercoagulable state does not mean everybody will be having. Pregnancy is a hypercoagulable state does not mean. If you say in pregnancy, fibrinogen is elevated, I understand. Because pregnancy is a hypercoagulable state. But not with respect to the word D-dimer assay. For that, it is like a very, very specific test that would be done. So I just want to emphasize that in the question of pulmonary thromboembolism, 3 tests or 3 aspects should be remembered. One is, he will always ask you what is the screening test. He will always ask you the investigation of choice. He will ask you regarding how do you determine the etiology, and then he will say what is the treatment for this condition. For all MCQs of pulmonary thromboembolism, the standard data is D-dimer SA. I reiterate my statement, प्रेगनेंसी में तो प्रेगनेंसी के केस में डी डाइमर ऐसे जो होता है वो बढ़ता है, डी डाइमर नहीं बढ़ता, फिब्रिनोजन बढ़ता है. अगर डी डाइमर बढ़ रहा है तो इट इज अ कॉज ऑफ कंसर्न. द इन्वेस्टिगेशन ऑफ चॉइस फॉर पल्मरी थ्रोम्बोबॉलिज्म इज सीटी पल्मरी एंजियोग्राफी. If he says etiologically क्या करेंगे, so we will have to go in for a DVT, that is a deep vein thrombosis के लिए we will have to go in for a Doppler of the extremities in a patient. And as far as the treatment of this condition is concerned, what we will be doing is using a medicine that you are all aware of, that is L-teplase. This is a thrombolytic medicine that will be used, and along with L-teplase, the second thing we will be using is a low molecular weight heparin, that is enoxaparin, will be used for this patient. These 4 points form the core information. These 4 points form the core information that you need to remember for the topic of pulmonary thromboembolism, screening, investigation of choice, etiology, and the treatment part. And as you can see from the options here, I mean, X-ray to non-specific. X-ray can help you in identification. Yeah, low molecular weight heparin. Exactly. X-ray will maybe help you pick up massive pulmonary embolism in a patient, but it will not help you identify small clots that are present. Okay. Pulmonary thromboembolism का मतलब ये होता है कि there's a big clot stuck bang in the middle of the pulmonary artery. अब वो क्लॉट आया कहाँ से था? तो लेग से आया था ना, इसको डीप वेन थ्रोम्बोसिस था. तो एटियोलॉजी के लिए क्या करेंगे? डॉपलर ऑफ द लोअर एक्सट्रीमिटीज. 2 times you will be doing Doppler in your entire medical studies. One is Doppler is done in Burgess disease, arteriovenous disorder में पढ़ते हो ना, Burgess disease in surgery. And second time Doppler will be done in diagnosis or deep vein thrombosis from where the clots टूट के, the clots are developing where? Soleal veins. और वहां से वो क्लॉट टूट के हार्ट में चला गया है. तो मुझे पहले डॉपलर करना है एटियोलॉजी के लिए, बट द सीक्वेंस इज लाइक दिस कि पहले करते हैं स्क्रीनिंग, दैट विल हेल्प यू इन आइडेंटिफिकेशन ऑफ दैट देयर इज अ हाइपरकोएगुलेबल स्टेट इन दिस गाय. डी डाइमरेट एसे इज ऑलवेज फॉर हाइपरकोएगुलेबल स्टेट. इन्वेस्टिगेशन ऑफ चॉइस इज CTPA. लेट मी शो यू दिस इमेज ऑल्सो. अगेन अ वेरी स्टैंडर्ड इमेज ऑफ योर एग्जाम. रेस्पिरेटरी सिस्टम में, इन द रेस्पिरेटरी सिस्टम दे ऑलवेज विल आस्क यू नॉट एस्थमा COPD, वो भी हम डिस्कस करेंगे, बट दे विल ऑलवेज आस्क यू रिगार्डिंग पल्मरी थ्रोम्बोबॉलिज्म, जिसको हम कम पढ़ते हैं. एंड व्हाट यू विल सी इन दिस केस इज दैट दिस इज पल्मरी आर्टरी और बीच में क्लॉट है वो फंसा हुआ है. इट इज कॉजिंग डिक्रीज ब्लड सप्लाई टू लंग्स. दिस इज द लंग्स LNL. दिस इज असेंडिंग एओर्टा. दिस इज द डिसेंडिंग एओर्टा. What you can see at the moment is the bronchus. These are the 2 bronchus. You can see posteriorly the vertebra, and you can also see the tissue of the spinal cord here. You can see the tissue of the spinal cord here. So if you look at the anatomy here, the problem is there's a big saddle embolus, as Nikhil is mentioning very rightly. This saddle embolus is the one which is the troublemaker and is contributing to these manifestations. If I want to destroy this clot, there is only one way, L-teplase. और इसका साइज और ज़्यादा इंक्रीज ना हो, फॉर दैट विल बी यूजिंग इनॉक्सापैरिन फॉर अवर पेशेंट. सो द पॉइंट टू बी अंडरस्टूड इज L-teplase is that clot buster medication that you are using, and enoxaparin is that drug that will prevent the further propagation of clot in this case. So the correct answer for the first question, PYQ that we have discussed, is D-dimer SA, because the question was very specific, what is first to be done. If we will change the language of the question, that is like how do you find the etiology, then answer is D. If he says what is the investigation choice, it is CT angiography. Embolectomy aparna is not done for this condition. We avoid doing, I mean, surgery will be a little difficult in this patient because BP is becoming unrecordable. How does L-teplase work? Well, it is a fibrinolytic drug, so it will generate plasmin, na? I mean, the mechanism of action of L-teplase is, it is a fibrinolytic drug. It will generate plasmin, and this plasmin will be converting fibrin insoluble. It will be converting fibrin insoluble into fibrin soluble. It is it's a generator of plasmin. It's a plasminogen activator. Plasmin क्या होता है? It's a clot busting medication that will convert fibrin insoluble into fibrin soluble. But every time you read about sudden onset respiratory distress, one of the causes that is to be remembered is currently discussed on the board, pulmonary thromboembolism. Let us do some more MCQs of sudden onset respiratory distress. I'll give you situations. First is you have done a central line insertion, and the MCQ is saying that patient is having breathing difficulty with drop in saturation. The second MCQ will say patient is undergoing neurosurgery and there is a sudden onset respiratory distress. The third MCQ is on a cigarette smoker who is having sudden onset respiratory distress. And the third was a patient who underwent joint implant surgery like total knee replacement like orthopedic implant surgery, and there is a breathing difficulty in a patient. Can I have answers for the first one? What is the important cause for sudden onset respiratory distress that would be seen after central line insertion? Hit the comment button, guys. Specifically, if he will say central line insertion and he says what is one of the leading causes of sudden onset respiratory distress, then your answer would be given as pneumothorax. Perfectly right. If I change this question to what is the number one cause of sudden onset respiratory distress in neurosurgery? Yes, or neurosurgery, sudden onset respiratory distress. What will you answer? Neurosurgery. And then there is sudden onset respiratory distress. Quick answers, please, guys. That is for the first one. No. In neurosurgery, what would be one of the leading reasons why this is happening? Yes, your answer is venous air embolism. Neurosurgery mein jo dural venous sinuses hote hain, they got injured. And because of the injury to the dural venous sinuses, what will happen is that when the sinuses will open, atmospheric air will be sucked inside. This atmospheric air that is sucked inside will then go towards the heart and will cause VAE, that is venous. He will use short form in the MCQ, venous air embolism. Cigarette smoker mein batao. Cigarette smoker having sudden onset distress, the answer will again be pneumothorax. This time it is rupture of the bulla. It is like a emphysematous bulla that will rupture. Or orthopedic implant surgery. Yes, spontaneous pneumothorax is a good answer. Waiting for the fourth one. Orthopedic implant surgery. Patient underwent total knee replacement. Patient, if I say anything more, the answer will become obvious. That is very good, very good. Guys, answer is not fat embolism. Ortho surgery लिखा हुआ है, that does not mean. No guys, answer is not fat embolism. Even after this, the answer is क्योंकि the orthopedic implant surgery would be occurring in the vicinity of the great veins. The answer here is pulmonary thromboembolism. I have explained that in my routine rapid revision. Now we're doing a LLR, that is the triple R series. It is pulmonary thromboembolism. Orthopedic पढ़ के आपने pulmonary thromboembolism को mark करना है. You're not supposed to answer it as fat embolism. If I was saying fracture of the long bone, suppose I was saying patient is having fracture of the long bone, like humerus is damaged, femur is damaged, only it is fracture of the long bones, that you should be answering it as fat embolism syndrome. That is why I kept it in the last, because maximum mistakes are made in this particular point. Guys, only if the MCQ will say fracture of the long bones will you say fat embolism. Otherwise your answer would be given as pulmonary thromboembolism. Yeah, there needs to be fatigue, there needs to be long bone fracture, but ultimately like orthopedic implant surgery mein to there would be like no fracture happening. In orthopedic implant surgery, patient is lying immobilized. इस operation के बाद में after total hip replacement and total knee replacement, patient will be lying in the bed now. There is the immobilization that is happening, and because of this immobilization part, what will happen is that there would be deep vein thrombosis and the clots will go. यहाँ पे total 5 MCQs मैंने cover किए. Sudden onset distress के central line insertion, neurosurgery, smoker, orthopedic implant surgery, fracture of the long bones. Each of them are having specific answers here, and especially for long bones it is fat embolism. Orthopedic implant surgery is pulmonary thromboembolism. We are sorted for the first question for today. In fact, we have discussed 5 MCQs here. Let's look at the next one. 40-year-old cigarette smoker comes with shortness of breath. He is a mason by profession. The spirometry shows FEV1 of 80% and FEV1 ratio of 0.8. I think you guys can come on the diagnosis of this patient. Okay, I'm getting COPD in the answer. COPD में क्या FEV1 FVC ratio 0.8 होगा? इज ऑल्सो मेसन ना, कंस्ट्रक्शन वर्कर बाय प्रोफेशन. कितने सारे कंस्ट्रक्शन वर्कर जो होते हैं सीमेंट का एक्सपोजर होता है और वो बीड़ी भी पीते हैं, सिगरेट भी पीते हैं, तो क्या उन्हें सीओपीडी होगा? या इस पेशेंट को वी विल रिलाई ऑन द रिपोर्ट. दिस वाज अ क्वेश्चन विच वाज बेस्ड ऑन योर एबिलिटी टू एनालाइज. लाइक सपोज इन दिस क्वेश्चन it was mentioned FEV1 FVC ratio of the patient to be less than 0.7. If this ratio was less than 0.7, you will say obstructive. If this ratio is more than 0.8, then you will say restrictive. So it's just testing your baseline knowledge. Don't get biased with the word cigarette smoker. Don't get biased by the word cigarette smoker. Focus on the timed vital capacity in this question. The correct answer for this question is option number B. जस्ट बिकॉज स्मोकर लिखा हुआ है आपने सीओपीडी नहीं बोलना है बच्चे. दैट्स द कॉमन मिस्टेक दैट अ लॉट ऑफ गाइज मेक. इट इज द टाइम्ड वाइटल कैपेसिटी दैट विल हेल्प इन डायग्नोसिस. इट इज द लैब्स दैट विल गिव योर डायग्नोसिस. इट इज नॉट गोना बी लाइक इट इज द लैब्स दैट विल गिव द डायग्नोसिस. इट इज नॉट गोना बी like the history that will give the diagnosis. सुट्टा मार रहा है तो क्या हो गया, मतलब ठीक है ना. Still you could be having interstitial lung disease developing in a patient. Sarcoidosis will be a young female with bilateral hilar lymphadenopathy, not given in this question with respect to hilar lymphadenopathy where you have non-gazetting gliomas. ACE levels are always elevated. Angiotensin converting enzyme levels are always elevated in sarcoidosis. And for lung cancer, he will always have to mention two things. One is hemoptysis. And second, apart from hemoptysis, he will also mention regarding weight loss, that is cachexia. So option number C and D were anyway ruled out. You have to select between A versus B. And the logic for this question is that COPD, you will diagnose on spirometry with FEV1 FAC ratio was less than 0.7. In this case, the ratio is elevated. So that goes in favor of like construction worker developing potential silicosis. Answer to second is option number B. Get the values right for this one. If you got this question correct, cool. If you got it wrong, please focus on the questions carefully. Let's look at the next question, which is again a repeat from the paper. COPD patients comes with increasing shortness of breath. On examination, a right parasternal heave is noted with a palpable liver. Right parasternal heave indicates right ventricular hypertrophy. The buzzword is right ventricular hypertrophy is present. There is a palpable liver. That means right side of the heart is getting affected. And on auscultation, there is a loud P2 that is heard. The moment you read the word loud P2, you know the diagnosis is pulmonary artery hypertension. Every time in your career, if you read the word loud P2, the moment you read the word loud P2, there can only be one answer in the question. This is the buzzword, loud P2 and loud parasternal heave that is present. That will help in diagnosis of this particular individual as option number B. This will help in diagnosis of this patient as option number B, that is pulmonary artery hypertension. Pulmonic stenosis के लिए क्या लिखा होगा? तो pulmonic stenosis के लिए, yes guys, you can comment. For pulmonic stenosis, there will be a murmur now, and the murmur intensity will rise in the middle of systole. So if the question was option number A, then there would be a ejection systolic murmur described in a question. Pulmonic stenosis presents with ejection systolic murmur, not given in this question. Pulmonary embolism, as I've discussed in my previous question, will always be having some findings for deep vein thrombosis described. More importantly, when it comes to, okay, I'll write this here, ejection systolic murmur. Pulmonary embolism के question में he will always mention regarding right ventricular failure, not hypertrophy, because clot is obstructing the pulmonary artery. So the question will always say widespread second heart sound. Anytime you read the word widespread second heart sound, मतलब right ventricle failure है. And if you read the word narrow spread second heart sound, it is left ventricle failure. For pulmonic regurgitation, there will be a early diastolic murmur that will be experienced by this person. So one, I want you guys to be familiar about the fact whether it is a systolic murmur, whether it's a diastolic murmur. Yeah, we are talking about early diastolic murmur or Graham steel that will come up later part. For today, minimum I expect you to remember are 4 words. Pulmonic stenosis, past mnemonic. Pulmonic and aortic stenosis causes ejection systolic murmur. Pulmonary embolism, right ventricle failure, because there is a clot occluding the pulmonary artery. Pulmonic regurgitation is early diastolic. Here the word loud P2 was given, because of which your answer is pulmonary artery hypertension. Can you tell me the drug of choice of pulmonary artery hypertension, guys? Quick comments, please. Quick comments, please. Also, please comment which city of India are you logged in from. I just want to check, curious, since yesterday we were doing surgery also. Just curious, which part of India are you logged in at the moment? Okay. Yes, drug of choice for pulmonary artery hypertension. Very good. That is bosentan is a drug. Eloprost bhi dete hain bache, but the main drug that we use for this patient is bosentan, which is the drug. Ambrisentan and bosentan are the endothelin receptor 1 agonist that would be used for management of this patient. Great. Okay, so I am having people from everywhere. Good. I'm having people from Srinagar, Delhi, Mumbai. So, okay, so this is pan India representation that we're doing at the moment. The main focus in this question is PAH to be remembered. Okay, moving to the fourth question for today. Patient had a fight with the bouncer. After dinner, he had vomiting episode and then he collapsed. On examination, there is the hyperresonance and absent breath sounds. This is what is the core issue to be remembered. Yes, guys, you guys can comment on the diagnosis in this case. Very good. Malarious cannot be the answer to this question because malarious will present with vomiting of blood. That is hematemesis. So option number B is ruled out. A lot of people in the paper got confused because it was written vomiting episode and then he collapsed. Boirav syndrome should always be having a macular striate. For macular striate, the presentation will be that of subcutaneous emphysema. For macular striate, there should be a mention with respect to chest pain. And then there should also be vomiting present. So when you read that question, there is rather lung findings which are given in this question. That lung finding will help you in identifying that this is a traumatic pneumothorax, because in collapse of the lung, there would be absent breath sounds, but you will not be getting hyperresonance. Hyperresonance word that is given in this question, hyperresonance word is, yes, it was dullness. Yes, Nikhil, it is right. Yesterday in last night when we were having this discussion in surgery, the TNE section, I had highlighted specifically that if it is dullness, then it is going to be a feature that is present for hemothorax in a patient. And today we talk about hyperresonance, so it is going to be pneumothorax. The correct answer to this question is option number A. This is one of the core things that you need to remember for this topic. Yes, we need to do a needle thoracostomy followed by a chest tube insertion in this patient. You have a very good point there. At the moment, I'm not saying tension, I'm saying the word traumatic pneumothorax, because tension pneumothorax है तो BP crash होना चाहिए ना. Or tension pneumothorax in a patient, it is the crashing of the blood pressure that should be happening. That's not happening here. I mean, he did not mention even tension pneumothorax in the options, but I take your point, BP should crash for the same. Moving to the next question. Known case of mitral regurgitation presents with shortness of breath. The X-ray is shown in this case. Again, a PYQ. Mitral regurgitation, I'll draw the line diagram for it. Meanwhile, you guys can check out the X-ray here. What is happening in this patient is that the mitral valve is leaking blood. In you and me, the left ventricle is not leaking blood into the left atria, but here you can see left ventricle is leaking blood into the left atria. Because of this, there would be a lot of congestion in the pulmonary veins. This will cause congestion in the lungs. So there would be a pulmonary edema developing in this case. Because the heart is the cause, you will say it is cardiogenic pulmonary edema. This is a simple question, guys, that the X-ray in this case is showing a bat wing edema. This is a bat wing pulmonary edema that is present in this patient. You can notice on both the sides the white and the X-ray is present. So the correct answer for this particular case is option number B. Cardiogenic pulmonary edema is the answer here. इसके ट्रीटमेंट के लिए we will have to give Lasix, morphine, nitrates, oxygen and positioning. But at the moment, like the main focus would be that for this particular patient, what we need to do specifically is use diuretic so that we can ease the pulmonary edema, and this is cardiogenic pulmonary edema. ARDS is usually seen after COVID-19. ARDS can be seen due to sepsis. So suppose this question was giving non-cardiogenic causes like swine flu, bird flu, COVID-19, that is SARS-CoV-2 virus. It was like, let me say, swine flu or sepsis, COVID-19, then it is ARDS, non-cardiogenic. Acute cor-pulmonale is the other word for pulmonary embolism. Acute cor-pulmonale is the other word for pulmonary embolism, where the clot will obstruct the pulmonary artery, and acute chest syndrome is a feature of sickle cell anemia. So what I'm trying to do here is to give you information for not one but all the four options in this question. Acute chest syndrome is a feature of sickling crisis. That sickling crisis would mean that there is going to be like sticky RBCs occluding the blood supply of the lungs. That is going to contribute to that sickling crisis that's called as acute chest syndrome. Mark my words, they're not acute coronary syndrome. Not the word acute coronary syndrome, it is acute chest syndrome. That's acute coronary syndrome occurs due to atherosclerosis. But acute chest syndrome will occur primarily because of the sickle cell anemia component, the sickling crisis that would be responsible in this case. So I think we are sorted for the fifth question for today. Let's move to the sixth one. A 60-year-old patient presented with low urine output and swelling all over the body. Blood urine nitrogen is 140. Serum creatinine is 8. So KFT of the patient is deranged, plus there is a proteinuria also. You can see here that the protein in the patient, proteinuria in the urine is 4 plus by dipstick. Considering this information, the kidney is suffering from a chronic damage. Which of the following is best used to differentiate acute kidney injury from chronic kidney injury? Okay, so this is, I think, last time's MCQ. Yes, guys, waiting for your answers here. Which of the following is the best way to differentiate acute from chronic kidney disease? Serum creatinine तो दोनों में ही बड़ा होता है. Urine output तो दोनों में ही कम हो जाता है. So either it will be the size of the kidney or it will be the urine albumin. The point to be understood is size of the kidney can be normal also or can be increased also, like in diabetic nephropathy. So it is not the size of the kidney, it is the urine albumin that will be useful here, because when you read about chronic kidney disease, in chronic kidney disease you check for two things: eGFR. When you will listen to me for chronic kidney disease, one I have described regarding the eGFR in a patient, that is estimated glomerular filtration rate. And the second thing that you will check in the patient will be albumin in the urine, that is albuminuria. So for chronic kidney disease, there are two things to be checked, that is estimated glomerular filtration rate and albumin in the urine. The severity in this patient is, yes, Nikhil, you're getting it right. It is A1, A2, A3. That is the severity that we use. So therefore, the answer to this question is option number D. Size of the kidney can be normal to increased in one of the most common cause of damage to the kidney, that is diabetic nephropathy. So I will not be basing my diagnosis. On the word size of the kidney. Diabetic nephropathy में kidney normal to enlarged होती है. Even in patients of HIV nephropathy, kidney is enlarged. Let's just focus on what conditions. You get bilateral kidney enlargement. You guys can comment here quickly in the chat. Please let me know which conditions will be having bilateral kidney enlargement. The answer to this question is D. Bilateral kidney enlargement is seen in diabetic nephropathy. Continue talking, guys. Hit the comment button. Make it like just go run riot. Yes, autosomal dominant polycystic kidney disease. Continue. Amyloidosis. Yes, diabetes. Autosomal dominant polycystic kidney disease. Amyloidosis. HIV associated nephropathy. These are all of the conditions. Autosomal recessive. Okay, good. So it is like these are like 4 must know conditions where bilateral enlarged kidneys should be remembered: diabetic nephropathy, autosomal dominant polycystic, amyloidosis, and HIV associated nephropathy are conditions for bilaterally enlarged kidneys. Must know fact for you. इन सब में chronic disease होता है guys, इन सब में CKD होता है, फिर भी तो kidney का size enlarged है. So size of the kidney cannot be useful for evaluation. Yeah, unilaterally enlarged is renal vein thrombosis. Nikhil, you're right. Thakur, it is like renal vein thrombosis usually unilateral. Hemolytic uremic syndrome में kidney size normal होता है. So it is not about the size of the kidney. It is albuminuria. That means proteinuria is present in the patient, which is why the answer will turn out to be option number D for this question. That is the 6th one for today. Let's move to the 7th one. A patient with mitral valve disease gets up from the bed after sleeping 3-4 hours a night, goes to the window and starts panting. वो उठ के खिड़की पे जाके खिड़की खोला, ऐसे सांस ले रहा है. He's saying I'm feeling suffocated. Even if he would have gone to the toilet, opened the door of the toilet and gone inside, still he will be like doing the same thing. It does not matter whether it is opening the washroom or whether it is the window. It is the position of the body that is changing. This is the characteristic manifestation for orthopnea, and the other name for orthopnea is paroxysmal नॉक्टर्नल डिस्निया, कि जब वो रात को जागेगा तो एकदम से 2-3 घंटे लेटेगा तो वेनस रिटर्न विल इंक्रीज. नो, इफ somebody will be lying supine, then the venous return to the right side of the heart will increase. The increased venous return to the heart will cause pooling of blood in the lungs, because more blood supply will then be going in the lungs, and pooling of blood in the lungs of the patient is a feature that is seen in orthopnea. It occurs after 3-4 hours of sleeping, so we call it P and D, paroxysmal nocturnal dyspnea. Answer to this question is option number A. Hit the comment button and let me know which of the following conditions would you be having trypopnea. Yes, which of the following conditions would you be having trypopnea? Trypopnea का मतलब होता है जब वो करवट लेके सोता है. करवट in Hindi is lateral decubitus position. Trypopnea would be Lateral decubitus position, when the person will turn to one side, that is when in lateral decubitus breathing difficulty will be occurring. Yes guys, waiting for your answer. In a lateral decubitus position, when patient will turn, there would be breathing difficulty. Which condition? Yes guys. Prepapnea is a feature. Orthopnea is a feature of heart failure. But trepapnea, that is lateral decubitus position, is a feature of pleural effusion. It is like a massive pleural effusion where this manifestation will be occurring. Massive pleural effusion where it would be occurring. When it comes to platypnea in a patient, platypnea is seen with atrial myxoma. In case of platypnea, the breathing difficulty will worsen in sitting position, like at the movement. Yeah, unilateral pleural effusion. Yes, massive pleural effusion, perfectly right. And if in sitting position, the person is having breathing difficulty, that is atrial myxoma, when you will be having platypnea present in the chap. So आपको तीन terms याद करनी है, orthopnea, tropapnea और platypnea. आज आप याद कर लो ऑर्थोपनिया हार्ट फेलियर एक, कल याद कर लेना ट्रेपापनिया, दैट इज अ फीचर ऑफ यूनिलैटरल प्लूरल एफ्यूजन ड्यू टू लंग कैंसर. एंड देन आप याद करना प्लेटिपनिया, दैट इज सीन विद एट्रल मिक्सोमा. दो आई हैव डिस्क्राइब्ड फॉर हिपैटोपल्मोनरी सिंड्रोम आल्सो, बट सिटिंग पोजीशन में बैठे बैठे सांस फूल रहा है, सो दिस अ ट्यूमर कॉजिंग ऑब्स्ट्रक्शन इन द हार्ट व्हिच विल हैव दैट क्लासिकल ट्यूमर प्लॉप साउंड प्रेजेंट. हाइपरअपनिया मींस फास्ट ब्रीथिंग. If I'm nervous, like you went to the examination center and you are a little late, so you will get nervous, and when you will get nervous, then you will start doing fast breathing. So hyperapnea का मतलब सिर्फ fast breathing होता है. I'm not talking about fast breathing here, I'm talking about position related breathing. So this is a very classical question of the paper that came, and the answer to this question is option number A. Standard general medicine presentation is orthopnea, worsening of dyspnea in supine position. जब लेटेगा तो more blood will come to the heart and that will cause worsening of this patient. Asthma may, I can just say hyperapnea can be present in exacerbation. Asthma patients will be having sitting up. Okay. So, I mean, I'll say asthmatic patients have more difficulty on lying. And when they sit up, they're relatively better. But orthopnea term is better for heart failure as compared to asthma. Your question is valid, Aparna. Like you said, asthma में क्या बोलेंगे? तो it's like the orthopnic position, like patient are sitting up, but then classical is heart failure thing. पिछले विंटर में उसने ग्राहम स्टील मरमर पूछा था. ऑस्टिन फ्लिंट एंड ग्राहम स्टील मरमर मस्ट नो आपके लिए. One topic that you always have to remember in murmur is Austin Flint murmur, which is a murmur of severe aortic regurgitation. The second murmur that I always want you to remember is Graham Still murmur. That's a murmur of pulmonic regurgitation. Graham Still murmur is seen in, the answer is, yes guys, pulmonary artery hypertension. The answer in question number 8 is option number B. Graham Still murmur is a feature that is seen with B, that is pulmonary artery hypertension. Two classical names are to be remembered. Pulmonary artery hypertension, say there would be like a severe, yeah, it is a severe pulmonary artery hypertension. You are perfectly right. And then severe will cause a mild pulmonic regurgitation. But here the main logic is that pressure is more. So that high pressure in the pulmonary artery will cause a pulmonic regurgitation. Please comment in the chat box, pressure in the pulmonary artery, more than how much is pulmonary artery hypertension? Pressure in the pulmonary artery, more than how much is pulmonary artery hypertension? Yeah, this will cause a early diastolic murmur. The murmur in this case is early diastolic. And the cause of this is a mild pulmonic regurgitation. I initially wrote both of them together so that you could remember it. Mild pulmonic causes early diastolic murmur. Yes, I think the updated guidelines are pressure more than 20 millimeter of mercury. Do remember this fact. Don't answer as currently as 25. In the current guidelines, it is pulmonary artery hypertension is defined as value more. But say 25 nahi bolna hai. Update is it's not 25. The updated this is more than 20 millimeters of mercury. The answer to question number 8 is option number B. The key word is Graham Still murmur. Pulmonic stenosis में मैंने बता ही दिया, it is a ejection systolic murmur. The mnemonic for that is PASS. PASS. Pulmonic and aortic stenosis results in ejection systolic murmur. Okay, चलो कमेंट करो. हाइपरट्रॉफिक कार्डियोमायोपैथी में कौन सा मर्मर होता है? What is the name of the murmur? What is the name of the murmur in patients of hypertrophic cardiomyopathy? Also tell me the pulse finding here. Murmur भी बता देना. हाँ, पुराने वाले नोट्स में ना बच्चे 25 मिलीमीटर मरकरी ना, अब अपडेट आ गया। मेडिकल साइंस में तो हर महीने अपडेट आता है भाई। मेडिसिन में दिक्कत क्या है कि फोरेंसिक मेडिसिन में तो जिंदगी भर वही चीजें हैं, 100 साल पहले भी वही पढ़ रहे थे। इन फोरेंसिक मेडिसिन 100 years ago it was same, 50 years ago, 10 years, they say the same thing, रटा रटाया चीज है। इन द फर्स्ट आवर ऑफ द नोट्स दे विल से द सेम थिंग, सेकंड आवर ऑफ द नोट्स दे से द सेम, कुछ चेंज ही नहीं होता। डेड आदमी है ना। यस। Graham Steele murmur, the pulse that is present is pulsus bispherians. Important statement to be remembered, that the murmur that is present in this condition is called as pulsus bispherians. That is a murmur of pulmonary artery hypertension. And when it comes to the murmur in this case, it would be a ejection systolic murmur. So two things have to be remembered: pulsus bispherians and ejection systolic murmur. This murmur will increase with Valsalva. Normally, Valsalva pe all murmurs will decrease. Normally, with Valsalva, all murmurs will decrease. The only murmur that will increase with Valsalva maneuver, the only murmur that will increase with Valsalva maneuver is the murmur of hypertrophic cardiomyopathy, where sudden death can occur while the guy is playing football. Okay. We are sorted for the 8th question. Additional details have been put up. For every question, I'm trying to put 2-3 extra details so that you can remember them as one-liners for the paper, including the update that I've mentioned. Pulmonary artery hypertension is pressure more than 20. Young female patient presents with binge eating followed by self-induced vomiting. I think this is one of the easiest questions for today. The moment you read this word vomiting, you know that the electrolyte imbalance that I'm talking about is hypokalemic metabolic alkalosis, because patient will be vomiting acid. So acid is going out of the body, and that acid that is going out will contribute to hypokalemic metabolic alkalosis for this patient. The correct answer to question number 9 is option number B. Very good strike rate for this question always is seen, metabolic alkalosis. कभी भी vomiting लिखा हो ना तो metabolic alkalosis बोलना। metabolic acidosis के लिए causes होते हैं cult. K would be for ketoacidosis, U would be for uremia, L would be for lactic acidosis, T will be for toxins, ketoacidosis, uremia, lactic acidosis and toxins. Cult is a mnemonic. Ketoacidosis, uremia. Instead of writing the word uremia, he may write words like acute tubular necrosis, acute glomerulonephritis. वो उसका headache है, but that cult mnemonic would make your life easier for metabolic acidosis. Respiratory acidosis will always be having increase of carbon dioxide. Must know example for respiratory acidosis. Must know example for respiratory acidosis is Status systematicus. The second example for type 2 respiratory failure or carbon dioxide retention causing respiratory acidosis is acute exacerbation of chronic bronchitis. Two must know examples that you must be remembering for buildup of carbon dioxide is status systematicus, and then is acute exacerbation of chronic bronchitis. For especially acute exacerbation of chronic bronchitis, we have to use non-invasive ventilation. Respiratory alkalosis will be having a carbon dioxide washout, and conditions that are causing a carbon dioxide washout would be anxiety, it would be pneumonia, it would be pleural effusion. So if it is anxiety, pleural effusion, pneumonia, ARDS, even if he says the word ARDS, yes, you're right, hyperventilation is the concept there, then you will say that you are dealing with a patient having respiratory alkalosis. So what I've tried to explain to you at the moment is like the standard questions that are asked on the 4 varieties, acidosis, alkalosis. वो compensation वगैरह भी नहीं पूछ रहा है यार, common चीजें पूछ रहा है. Yes, high altitude also, your answer is perfectly right for high altitude causing hyperventilation, but that's the minimum level of performance that is expected from you. Okay. Moving to the next one, a patient presents with headache, vomiting and nuchal rigidity. A guarded lumbar puncture was done and shows a turbid CSF. Cult also for Hagma. Yes, Akil. There's a turbid CSF with neutrophils. Sugar is only 40 and protein is 200. If you look at the information here, the first thing that is very classical is neutrophils are present. 90% neutrophils will be present here. Sugar is only 0.3. If you look at the maths here, it is 40 divided by 120. The value of sugar in this patient CSF is only 40 and the actual in the blood is 120. So the ratio is 0.3. Normally, I have taught you for a normal person, the sugar ratio should be more than 0.6. दिस पर्सन इज हैविंग हाइपोग्लाइकोरेकिया, नॉर्मल पर्सन में जो शुगर होना चाहिए CSF में वो इक्वल टू मोर देन 0.6 टाइम होता है. This is 40 by 120, that is point number 3. So therefore there is less sugar present and protein is elevated. So the diagnosis is acute bacterial meningitis. The chap is having pyogenic meningitis. For myogenic meningitis, it is empirical treatment that must be started in this case. So we will be starting the patient on ceftriaxone plus vancomycin. Acyclovir तो वैसे ही बाहर हो गया ना यार. You don't start antibiotic with antiviral treatment, so it is out. So either it had to be B versus C or tubercular meningitis, and tubercular meningitis will always be having CSF lymphocytosis. Like if in this MCQ he mentioned regarding CSF lymphocytosis, then I would have thought of as anti-tubercular drug. And I think all of you are aware that now ethambutol is gradually being replaced. The new medicine that can be used in place of ethambutol is moxifloxacin. That's just an update that you should be aware of. That is in the Center for Disease Control Atlanta guidelines, that the new antibiotic that is being used in place of ethambutol nowadays is moxifloxacin. And CSF lymphocytosis is like the keyword in a question. Yeah, cobweb coagulum, sugar is low, proteins are elevated, that are classical. In fact, more important is the value of the protein. The more important is the value of the protein. If the CSF protein of the patient is more than, if the CSF protein of the patient, if the CSF protein of the patient is more than 1 gram, then we can say it is like talking about super elevated protein. And cobweb coagulum, cobweb coagulum may not be given, but protein elevation is like a very characteristic feature. Yeah, pretomanid is being used and moxifloxacin is being used. There are two of them. First answer is moxifloxacin. Second is that pretomanid that is being used. These are two like updates that have come. Center for Disease Control Atlanta only is saying it, not the other one. So the answer for this question is option number B, ceftriaxone vancomycin. ये क्वेश्चन तो इतनी बार आ गया है अब तो कि I think all of you, the moment you would have seen this question, you would have been like, oh man, this is Indian preparation. I know the answer. HIV positive patient came with fever and vomiting episode. There's nuchal rigidity. There's lymphocytic pleocytosis, and that Indian preparation is shown in this case. So we will have to give liposomal amphotericin B, and along with that, we'll be giving flucytosine for management of this patient. The correct answer is B. Extensively asked, guys, extensively asked. Every time he has talked about this topic, it is liposomal amphotericin B and then 5-flucytosine that would be used for management of this patient. The correct answer is option number B. Yeah, the correct diagnosis is India ink preparation is revealing cryptococcus. The main issue in this chap is it is cryptococcus meningitis. It is cryptococcal neoformans. It's a capsulated organism, and the capsulated organism is the troublemaker in this case. That the organism has a capsule. The capsule is not stained. It is the background that is not used. I think we have discussed this multiple times. I'll say this again. इसको पहले हम देते हैं liposomal amphotericin B with 5-flucytosine. We give two things together. We give liposomal amphotericin B with 5-flucytosine to this patient for 2 weeks. That is the initial treatment. And then on discharge, we will be putting these patients on fluconazole. So fluconazole को हम liposomal amphotericin B के साथ नहीं देते. On discharge, the patient is put on oral fluconazole, which would be given for 10 weeks. It is oral fluconazole for 10 weeks. So the total would be something like 12 weeks that would be used for this patient. The correct answer is option B. Rationale behind why answer is not A is first, liposomal amphotericin B को fluconazole के साथ नहीं देते. Liposomal amphotericin B is not given with fluconazole. It is on discharge this medicine would be given to the patient. So we are sorted for this question, guys. I think this was highly, it was like last time tak na, this question was like people were taking it casually. Even treatment nahi puchega, diagnosis puchega. He asked the treatment part there. It is liposomal amphotericin B. That's one of the main drugs that is used. And complication of this is also asked, hypokalemia and hypomagnesemia. Okay, answer to 11th is option number B. Fine, 11th is sorted. I hope all of you are doing great with respect to tea and coffee to study long hours, right? Even I need coffee in between, but then like I think you guys would be doing too much of coffee and tea nowadays. Okay. Patient with liver cirrhosis he presents with massive ascites. He says which of the following is the incorrect statement about this condition. Then we have to remember SAG, serum albumin ascites gradient, that would be given in this case. So serum albumin ascites gradient, very good. Serum albumin ascites gradient of less than 1.1 is the problem in this case. It is always more than 1.1. Let me just explain this to you. SAG value, if it is less than 1.1, then the causes to be remembered by you are TPN. Then the causes to be remembered by you are TPN. T is not, I mean, we're not talking about total parental nutrition. It's not total parental nutrition. Yes. If it is, yeah, that is the wrong statement he's asking. Na beta, it is, he's asking incorrect statement. That would be the less one. More. Yes, more is okay. Less is bad. The wrong thing is value less than 1.1. That is for TB. Yes, the second one is for pancreatitis and peritoneal carcinomatosis, like lung cancer. Sorry, ovarian cancer is metastasizing to the peritoneal cavity. So this is peritoneal carcinomatosis. That's a feature that is seen with stomach cancer. Ovarian cancer, they metastasize to the peritoneum. Yes, bile leak is also there, but then I did not incorporate bile leak because that is what they teach mainly in surgery. So it is gonna be nephrotic syndrome here. And you're right, one of the important causes is the bile leak as well. So the causes of serum albumin ascites gradient being less than 1.1 are the ones that were quizzed in this question. And portal hypertension due to cirrhosis is always this value. So A option is correct. If you look at the C, check the ascitic fluid, because the mathematical formula is serum albumin minus ascitic fluid albumin. You will check the albumin in the blood. You will check the albumin in the ascitic fluid. So serum albumin ascites gradient, and then is occurs due to portal hypertension. So portal hypertension is one of the leading causes for development of this. So this is okay. Ascitic fluid protein evaluation is fine, and the value being more than 1.1 is okay. But considering if you look at option B, that's the wrong statement here, because that would be seen with TPN. So bit of cramming and remembrance has to be done for this question. This question was a combination of like cramming the data and then being able to recall it in the shortest possible time frame. 12th is sorted. Let's look at 13th. Yes. For the 13th one, there is a known case of heart disease. It's not written rheumatic heart disease. It's saying known case of heart disease with sore throat presents with shortness of breath, hyperdynamic precordium with water hammer pulse is present. The moment you read the word water hammer pulse, you know that you're dealing with valvular aortic regurgitation. Pistol shot sounds are heard over the femoral arteries, again aortic regurgitation. Collapsing pulse is also called as water hammer pulse, and we have pistol shot sounds. And auscultation shows a pan-systolic and early diastolic murmur. So for aortic regurgitation, we've discussed now, they can be an early diastolic murmur if aortic regurgitation is mild. If it is severe, we go for a mid-diastolic murmur, and there's the pan-systolic murmur also. The reason for the pan-systolic murmur is mitral regurgitation. The correct answer to this question is option number A. This is again a PYQ, very classical. Pistol shot sound and water hammer pulses aortic regurgitation, वो तो solve हमने कर ही लिया, तो दो option तो बाहर ही हो जाते हैं. All you had to do in this question was identify the word pan-systolic murmur. Pan-systolic, I'll give a diagrammatic representation, would be like this. In fact, let me just rephrase. This is S1, this is S2, that is S1. Systole is always shorter than diastole. Systole is always shorter than diastole, and you will have a murmur all through the duration of systole. This one is called as pan-systolic murmur. इसमें intensity uniform रहता है. In patients who are suffering from aortic stenosis, it's a ejection systolic murmur, crescendo decrescendo. Here it is a pan-systolic murmur that would be present. So the answer to question number 13 is option number A. Let's move to the 14th one. Correct about Mobitz one heart block. Mobitz one heart block would be having a ECG like this. I'm going to show it quickly here. There's a PR interval prolongation. It's increasing. It's increasing further. And then there would be a P wave followed by a missed beat, and the whole cardiac rhythm in the patient will be reset. This serial prolongation of the PR interval of the patient is what is called as Mobitz one heart block in a patient. Gradual prolongation of PR. Yes, I think everybody got this right. Gradual prolongation of PR followed by missed beats is the answer for Mobitz one heart block in a patient. Arteriovenous dissociation. This is third degree heart block, guys. Arteriovenous dissociation is third degree heart block. Prolonged PR interval is first degree heart block. What is left here is normal PR followed by missed beats. This normal PR followed by missed beats is Mobert's heart block. So each of these options have been created to cause confusion. But yes, you were smart enough to realize कि भाई Mobert's one में तो Wenckebach phenomenon होता है. That Wenckebach phenomenon will be causing, yeah, going and gone. That's how we can remember it. But it's a better way to remember the gradual prolongation part. That's easier to remember. Yeah, in fact, like prolonged, I should have mentioned it, prolonged PR interval only, not shortening. If I remove this, because you cannot have a shortening of the RR. No, RR will be normal with respect to first degree heart block. Nikhil, you're right. I did say that verbally, but yeah, I should have pointed that out. Prolonged PR interval alone is a feature of first degree heart block with no changes in the RR interval, as has been asked earlier. Okay, so answer to 14 is option number A. Let's move on to the next one. यार वो ना गलत बता रहे हैं, long and gone नहीं होता है. It is long and ultra long. Then there's a drop. It is long. It is long, longest, longer, longer, longest, and then a drop. It's not long and gone. They're trying to simplify things, but then the concept is getting missed there, na? Sir, it is long, longer, longest, drop. That's the word here. Long, like अगर mnemonic की बात करनी है तो वो राइमिंग कराने के लिए चक्कर में ना दे आर मिसिंग. रैप सॉन्ग बना दिया उन्होंने कि मोबेट्स वन हार्ट ब्लॉक का रैप सॉन्ग ये होता है, मोबेट्स टू का रैप सॉन्ग ये होता है. इट्स ओके. आई मीन एट द मोमेंट द क्वेश्चन इज स्ट्रेट फॉरवर्ड, सो यू आर एबल टू फिगर दैट आउट. बट व्हाट आई वांट टू से इज द टेक्निकल वर्ड इज लॉन्ग, longer, longest, drop. That's the word to be remembered. Okay, so answer to 14 is option number A. We can move on to the next one. A patient with a history of viral infection 2 weeks back comes with ascending symmetrical flaccid paralysis. Again, the key word here is ascending bilaterally symmetrical lower limb flaccidity. This is a classical manifestation that you will be noticing with respect to patients of Guillain-Barré syndrome. Yes, the correct answer to this question is option number A. Acute inflammatory demyelinating polyneuropathy is the answer to the current question on the agenda. Yeah, GBS. Tell me the drug of choice for GBS, please, guys. Drug of choice for GBS, please. It's one of the commonest variants of GBS. Yes. Yes, very good. Quick answers, please. Drug of choice is intravenous immunoglobulins. We can also do plasmapheresis, but it is relatively less effective. So our answer is IVIG to be used. Which cranial nerve is involved in multiple sclerosis? Which nerve is involved in multiple sclerosis? The answer would be cranial number 2. It is the second cranial nerve. It is the optic nerve that would be affected in this patient of multiple sclerosis. No, बच्चे, not the third nerve. Multiple sclerosis में blind हो जाता है ना patient. It's a female patient with Utah phenomenon. She'll go blind. So it's the optic nerve. It is olfactory first or optic 2. So it's the optic nerve that is involved. Second cranial nerve. सहमत तो इसका आंसर है ना. गुलियन-बारे सिंड्रोम में सेवंथ नर्व की इन्वॉल्वमेंट होती है जिसको हम फेशियल डाइप्लीजिया बोलते हैं. इन AIDP इट इज द सेवंथ नर्व, बट इन मल्टीपल स्क्लेरोसिस इट इज द सेकंड नर्व इन अ पेशेंट. Tell me the drug of choice of multiple sclerosis, please. Drug of choice for multiple sclerosis. Quick revision, guys. ऑप्शन देने पड़ेंगे. वही मिथाइल प्रेडनिसोलोन, ओक्रेलिजुमैब, नाटालिजुमैब. Yes. For acute attack, we will give high potency steroids. Yes, because she's having blindness at the moment, so we will give high potency steroids to this patient. For prevention, we can be using, obviously, like preventing these attacks, we can be using ocrelizumab, natalizumab for the patient, beta interferon also. But for acute attack, it is like methylprednisolone, because at the moment she's having an acute attack, so I'm talking about methylprednisolone. Amyotrophic lateral sclerosis is again a very famous topic of your exam. बस इतना याद कर लेना, इसमें lower motor neuron lesion and upper motor neuron lesion दोनों के फीचर दे रखे होंगे. Patient will be, or question will be beginning like this, that the person की leg में there is flaccidity, and in the arm of the patient on the same or the opposite side there is spasticity. The moment you read that in the leg there is ulta bhi ho sakta hai, in the leg there can be spasticity, in the arm there can be flexibility. Normally it is pure lower motor or pure upper motor. If you get a combo, then it is always amyotrophic lateral sclerosis कि उसको फ्लैसिडिटी भी है, उसको स्पास्टिसिटी भी है, और यहाँ पे जो प्रोग्रेशन होता है वो अल्ट्रा स्लो होता है. व्हेन द डिजीज विल प्रोग्रेस ओवर मंथ्स टू ईयर्स. Amyotrophic lateral sclerosis will progress over a couple of months to years. So it's always only MCQ where upper motor, lower motor is given is one is B12 deficiency and second is going to be amyotrophic lateral sclerosis. And when it comes to spinal cord injury will contribute to development of neurogenic shock in a patient. There would be flaccidity initially in spine. In fact, I can write the word spinal shock. Spinal cord injury will contribute to spinal shock developing in a patient. The drug of choice for spinal shock. Quick answers, please. What is the drug of choice for spinal shock? Yeah, Babinski sign can be given, but Babinski to पैर में होता है ना, तो spasticity in upper limb में तो will not get a Babinski sign. But your point is right. If दूसरी leg में spasticity आ जाती है, then it's gonna be like yeah, methylprednisolone. Lavish, you were right. 2 times methylprednisolone is the drug of choice here. In endocrine system, we read methylprednisolone. In endocrine system, we will always read about methylprednisolone. For the topic of endocrine methylprednisolone होता है Graves' ophthalmopathy. But today methylprednisolone has been discussed not for Graves' ophthalmopathy but for multiple sclerosis, acute attack and spinal shock as well. 15th is sorted. Let's come to 16th. Young female comes with vomiting episodes for past few days. Interpret the ABG report. It was again a very funny question because if vomiting is written, then वो ABG report नहीं भी देता फिर भी solve हो जाता है. You can notice that in this question all are going up. pH is going up, PCO2 is going up and bicarbonate is going up. If all the arrows go up, it has to be a metabolic alkalosis and it would be a hypokalemic metabolic alkalosis because there would be a hyperaldosteronism developing in this patient also. That is a hypokalemic alkalosis. 16th is sorted. Let's move to 17th. Patient underwent a cholecystectomy and black pigmented gallstones are noted. The moment you read the word black pigmented gallstones, you know patient is suffering from hemolytic anemia. The patient is having multiple episodes of shortness of breath and chest pain requiring hospitalization. He is talking about acute chest syndrome. If he would have said that the patient is from Odisha or from tribal India, I would have thought in terms of sickle cell anemia right away. So he did not mention the ethnicity or the state background of the patient. But the moment you read this, you know that you're dealing with sickle cell anemia. The characteristic feature, guys, is a sickle cell anemia, which is primarily because there are sickling episodes developing in the chap. And because of the sickling, sticky RBCs होते हैं, वो vaso-occlusive crisis करते हैं, which is why sickle cell anemia is the issue for which the drug of choice has also been asked. I think you're all aware that the drug of choice for sickle cell anemia, as asked in last time's paper also, is hydroxyurea. Answer to this would be the answer to this question would be given as option number D, that is sickle cell. Okay. In a patient with electrical burns, red color urine is obtained. The moment you read the word red color urine, either it is hematuria or it is gonna be myoglobinuria. Electrical burns में crenazumab is given is like crenazumab is a monoclonal antibody to reduce the frequency of sickling episodes. But recently उसके जो side effects हैं they are pretty severe. So voxelotor is withdrawn. Like voxelotor was mentioned in the MCQ, अभी इसको withdraw कर लिया है. And crizanlizumab will be used to reduce the frequency of sickling episodes. यहाँ पे क्योंकि रेड कलर यूरिन दे रखा है, so it's gonna be myoglobinuria. And moment I say the word myoglobinuria, skeletal muscle in the patient will be affected, and because the skeletal muscle will be destroyed, that is why there would be increased CKMB levels. Creatinine, phosphokinase, MM levels, it's coming from the skeletal muscle, would be increased in the patient. If this question was on glomerulonephritis, that I would have thought in terms of RBCs in the urine, but this is not glomerulonephritis, it is myoglobinuria. The remaining two options are dummy choices, calcium and conjugated one. Yeah, I mean here the RBCs part would be lesser, it's mainly gonna be like muscles that are present. Increase CKMM levels. Okay, we'll do till 20, then we take a 5 minutes break, then we'll do the remaining ones. Patient sustained a road traffic accident and there's a fracture of the shaft of femur. Because he's mentioned the word shaft of femur, I've already sensitized you if there's gonna be a fracture of the shaft of femur and breathing difficulty in 48 hours. TK will take some time to appear. CNS manifestation will also be affected. We use GERD criteria. No, 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 no. If it is fracture of the shaft of femur and is having a breathing difficulty, we'll go with fat embolism syndrome in a patient. If it is ARDS के लिए तो mainly sepsis होता ना. ARDS के लिए तो he should mention this ratio ना, PaO2 FiO2 ratio. There is no mention of X-ray findings of bilateral infiltrates in these patients. Bilateral infiltrates. More importantly, when you will do echo in the patient, echo will be revealing in ARDS, left atrial pressure should be normal because I want to rule out cardiogenic pulmonary edema. The correct answer to this question is acute respiratory distress syndrome. It is option number A that should be answered. Okay, you are having issues in this one, so let me explain again. एक्यूट रेस्पिरेटरी डिस्ट्रेस सिंड्रोम इज नॉन कार्डियोजेनिक पल्मोनरी एडीमा। यार यहाँ पे तो कहाँ पे लिखा है कि उसको एक्सरे में बायलैटरल इन्फिल्ट्रेट्स हैं, PO2 FiO2 रेशियो का वैल्यू भी नहीं दे रखा है। इकोकार्डियोग्राफी, लेफ्ट एट्रियल प्रेशर, नॉन कार्डियोजेनिक पल्मोनरी एडीमा। सो ARDS के लिए फॉलोइंग इश्यूज होने चाहिए, स्पेशली जो एक्सरे होगा ना उसमें एक्सटेंसिव वाइटनेस होगा। ये तो मैंने अभी हल्का दिखाया था ना, एक्सटेंसिव बायलैटरल। अगर इफ दिस क्वेश्चन सेड इन्फिल्ट्रेट्स, एक्सटेंसिव इन्फिल्ट्रेट्स, आई वुड हैव थॉट इन टर्म्स ऑफ acute respiratory distress syndrome in a patient. ट्रिगर भी तो देखो, सेप्सिस होना चाहिए, ट्राली होना चाहिए, ट्रांसफ्यूजन रिलेटेड एक्यूट लंग इंजरी इन अ पेशेंट। कॉजेज कैन बी सेप्सिस, इट कैन बी ट्राली, इट कैन बी निमोनिया, it can be Mendelssohn syndrome where there is a aspirational stomach acid. So some kind of triggers would be given in a question for the answer of yours as acute respiratory distress syndrome. ये भी बड़ा क्वेश्चन, इस बच्चे का फोटोग्राफ बड़ा फेमस हुआ था। चाइल्ड प्रेजेंट्स विद लोअर हाफ ऑफ द फेस पैरालिसिस with drooping of one corner of the face. You can notice that on this particular side he cannot close his eyes. There is drooping of face on this particular side and there is loss of vertical lines. यहाँ तो vertical lines can be there, no? Vertical lines can be produced on the forehead, but on this side there is no vertical lines on the forehead of this patient. I'll erase the markings here so that you can appreciate them better. You can see here, if I zoom into the figure, on the right hand side of this patient, let me say this is left and this is right. This is left and this is right. So on the right hand side in this patient, you can notice person can close his eyes. और मुंह टेढ़ा हो गया ना, एक साइड पे बंद हो गया. So it is a infranuclear palsy that is happening in this patient. It is a, गलती नहीं करना यार, I think A आ रहा है. It is left ना, अरे left और right में गलती कर रहे हो. चलो देखो, कोई भी इमेज होता तो उल्टा होता ना, left and right. राइट ऑफ दिस पेशेंट इज नॉर्मल, तभी तो आंख बंद कर रहा है गाइस। आंख बंद कर रहा है मतलब नॉर्मल है, and he is not able to close the eye of the other side, so it is left sided. It is infranuclear palsy. It is a infranuclear palsy on the left hand side. Left side पे hypotonia हो जाएगा, hypotonia हो जाएगा, ipsilateral कर लो, hypotonia कर लो, that is how you'll be able to solve it. So the correct answer for this question is option number C, that is a infranuclear palsy of the left side, which is to be remembered. Okay, तो चलो यार 5 minutes का break ले लेते हैं. We'll just take a quick short 5 minutes break and then we're gonna resume in like 5 minutes from now. Time is 7:39. I'm gonna start by 5 मिनट कितने हो जाएंगे, 7:50. मैथ्स भी कमजोर हो गई है एज के. 7:45. Okay, so give me 5 minutes guys and we'll start. Super nuclear is for stroke man. सुपर, चलो मैं अभी वापस आता हूँ तो आई ड्रॉ द डायग्राम फॉर सुपर एंड इंफ्रान्यूक्लियर एंड विल क्लैरिफाई फॉर इट फॉर वंस एंड फॉर ऑल कि कब सुपर न्यूक्लियर बोलना है और कब इंफ्रान्यूक्लियर बोलना है. आई विल एक्सप्लेन इट टू यू बट लेट्स डू इट लाइक आफ्टर अ फ्यू मिनट्स. ओके गाइस, प्लीज जॉइन बैक एंड वी कैन गेट स्टार्टेड. What I was mentioning is regarding the supranuclear and the infranuclear palsy. So I'll draw a quick diagram representing the same. If you get an image-based question in which the patient is having drooping of the face on one side, if you get a question in which the patient is having drooping of face on one side where the saliva can be leaking from the corners of the mouth also, you'll be wondering to yourself, is it supranuclear palsy or is it infranuclear palsy? If it is Bell's palsy, you will notice a very characteristic manifestation of Bell's phenomenon. When you will ask the patient to close his eyes, there will be uprolling of the eyeball of the patient. When you will forcibly ask the patient to close his eyes, then there would be uprolling. Black of the eye upar chala jata hai, that is uprolling the eye, that is called as Bell's phenomenon. In this condition, you will notice that the patient will be having inability to close the eye, but they may not be presence of any Bell's phenomenon. तो आप बोलोगे कि इस image में भी तो he is not having Bell's phenomenon, so why did you say lower motor? The main difference is what I say next. In Bell's phenomenon, you will be having absence of frowning or vertical lines on the forehead on one side. Like in this particular diagram, I have shown that on one side of the face, there is like complete absence of frowning, whereas in upper motor neuron lesion, there would be frowning present on both sides because forehead will be having a bilateral representation. So if you look at this diagrammatic representation, then I can say that the patient is having weakness only on this particular side, that is with respect to the lower face of the patient, because in stroke the contralateral face will get involved but forehead बच जाता है. So simply ask the patient to produce lines on the forehead. Ask the patient to produce lines on the forehead. If he cannot produce lines on the forehead in half, it is a infranuclear palsy. This infranuclear palsy is the one that is being talked about. We call it Bell's palsy. But if it is only the lower part of the face that is involved, frowning on the face is present, there is no Bell's phenomenon present, then we will say it is a supranuclear palsy on the contralateral side in a patient. So just by looking at the image, if whole of the half face, here if you look at the representation, whole of the left face of the patient, including that Bell's phenomenon part, is getting involved, whereas in stroke it is only the lower part of the face that is getting involved. So he says half face versus contralateral lower face involvement, which will differentiate. Okay, so this light diagrams highlights the supra versus infranuclear. Supranuclear is always contralateral, infranuclear is always same-sided. 20 is an image that must always be remembered. We move on to 21st. Okay, let me just check out your answers there as well. Okay. Patient has been diagnosed with mitral stenosis. What is the determinant of severity of mitral stenosis? This came in last time's paper ना, ये FMG exam का ही तो photo है भाई. This came in FMG paper, not in NEET PG. This is infranuclear palsy on the left side. Patient has been diagnosed with mitral stenosis. What is the determination of severity of mitral stenosis? I'll draw a line diagram for the same. This is S1. FMG paper of last time was more difficult than NEET PG. I've solved both of them on the viewer there on YouTube. देख लेना दोनों को. In patients of mitral stenosis, this is the opening snap. It will be a loud opening snap followed by a murmur. If mitral stenosis will become more severe, then opening snap will also become louder and will occur earlier. So you can look at this line diagram and see that the murmur will be occurring relatively earlier in a patient. This gap is becoming lesser. This S2 and opening snap gap is becoming relatively lesser. This decrease in the gap between the S2 and the opening snap is the severity of the disease, because if the opening will become smaller, then the murmur will become relatively longer in a patient. The correct answer for this particular one that I'm currently mentioning before you should be answered by you as option number B. It is reduced opening snap gap, which is to be remembered. यार पेपर जो होता है इंग्लिश में होता है भाई. अब लास्ट मोमेंट पे आप शुद्ध हिंदी की बातें मत करो. पेपर तो इज इन इंग्लिश ना. लॉट ऑफ पीपल वर नॉट एबल टू अंडरस्टैंड द वोकेबलरी ऑफ द क्वेश्चन. तो प्लीज अप्रिशिएट दिस फैक्ट. पेपर अगर मेरे लिए तो आसान है, मैं मदर टंग में बात करूंगा तो हिंदी में मुझे समझाना भी आसान है, लेकिन पेपर में पीपल आर नॉट एबल टू अंडरस्टैंड द ऑप्शंस. कह रहे कि सर वो दोनों ही सही लग रहा था ना, बिकॉज वी फोकस ऑन हिंदी मीडियम बट देन द पेपर इज इन इंग्लिश ना. सो इन द एंड आई ऑलवेज टेल स्टूडेंट्स टू स्विच टू इंग्लिश वर्जन. गेट यूज टू इट. जैसे एग्जाम से एक हफ्ता पहले यू मस्ट प्लान योर मील्स. आई वाज टॉकिंग टू अ गाय टुडे. ही सेड कि एग्जाम में ना आई हैड लाइक मॉर्निंग में he used to have a habit of waking up late. So one day he had to get up early for the paper and he had milk and banana and he vomited at the center and he was not feeling well, so the paper went bad. Because if you don't eat banana and if you don't eat milk every single day and you wake up at 12 o'clock in the afternoon or 1 o'clock in the afternoon, then you can't wake up in the morning. No, I'm giving that example to say that meal timing is important. I see the language of instruction is also important. That in the end, try to focus more on English because hardcore information in English is being given. Okay. Patient has been diagnosed with mitral stenosis. Severity of mitral stenosis. Severity of mitral stenosis is inversely related to S2 opening snap gap. The severity of mitral stenosis, I'll write it again inferiorly. Severity of mitral stenosis, guys, is inversely related to S2 opening snap gap. That's the statement to be remembered for this one. The answer to this question is option number B. 21st is sorted. Let's move on to 22nd. Patient came in the emergency room with pain on the left side of the chest, radiating to the left arm and shoulder, lasted for 20 minutes. ECG shows a ST depression in the precordial leads. So I am thinking in terms of MI in a patient because troponin I is elevated. He said, what is the next best step in management of this patient? Can I have answers, please? Yes. I will be giving aspirin and I need to give clopidogrel. It is dual antiplatelet therapy. It is DAPT, dual antiplatelet therapy that should be given in all of these patients. This is very simple. No, it's not DOAC. It's not DOAC. That would be oral anticoagulants. Don't answer DOAC, bache. DOAC is gonna be that apixaban, rivaroxaban. It is dual antiplatelet therapy that I'm talking. The DOAC is directly acting oral anticlotting agents. The DOAC or NOAC is like apixaban, rivaroxaban. This is DAPT. It is dual antiplatelet therapy in any patient of MI is the first treatment to be given. Nowadays, you're aware that in non-ST elevation MI also, we go ahead with PCI. So the treatment of choice for this condition is PCI only, but then the point is initial treatment is all he has asked. So the answer is dual antiplatelet therapy. 22 is sorted. Which of the following is correct regarding a first degree heart block? So this is okay, Nikhil, you mentioned it earlier only. So I think that's why people will be able to get this one right now. In first degree heart block, there is a prolonged PR interval because there is damage between the area of the SA node and the AV node. This is SA node, then is the AV node, this is the normal conduction, then the current will go into bundle of phase. So the damage is present in this area between the SA node and the AV node. That's where the damage is present. Yes. Each P is followed by a QRS and a normal RR interval. Perfectly right. The correct answer to this question is option number B. RR interval does not get prolonged in first degree heart block. It is rather in MOBITS 2 where the RR interval will get prolonged, but here it will be normal. The correct answer for this question is option number B. Let's move on to the next one. In ACLS, which of the following is correct about the component that is shown in this particular case? As you can see from the representation, doctor is standing with his hand around the shoulder of the patient. So he is trying to help in the recovery of the patient. The correct answer in this case is option number B. It is like you are first finding the cause, you're calling code blue, emergency call, giving chest compressions to the patient. Then is gonna be the, DC shock, then is recovery, post-care recovery. Post cardiac arrest. This is post cardiac arrest care where we plan therapeutic hypothermia. This is defibrillation, as you can see. Otherwise, it is resuscitation, call for help, find the cause. But then it is like recovery that is being talked about at the moment. The answer to this question is option number B. In hospital cardiac arrest and out of hospital cardiac arrest is again that they love to ask. If it is in the hospital, we try to find early recognition is the point here. We're trying to find the cause. Shockable rhythm versus non-shockable. What I mean by early diagnosis prevention is shockable versus non-shockable rhythm. If it is outside the hospital, then there is like straight away the mobile. You have to call emergency services and start CPR in the patient and transfer. Here ambulance will also be shown because you have to transfer the patient with an ambulance. So OHCA is easy to identify from IHCA, but the common thing between both of them is, as you can see in the figure now, recovery is a critical care that is usually part of the recovery. The protocol for management that is usually neglected. Recovery is towards the end. After, like you can see, yes, similar. Both of these are similar here, but then there are certain differences which are present, and it is those differences which I think that you will be able to identify on the basis of an ambulance photographer out of hospital. OHCA is out of hospital cardiac arrest. IHCA is in hospital cardiac in hospital cardiac arrest. Yeah, I mean, yeah, scene safety is understandable. We have to check scene safety and everything, but this is like a slow burn. Na? They did not make any logo for scene safety because that's a relative statement. So this is American Heart Association chain of events that would be done for management of our patient. It's a logo to explain for paramedical workers, not for doctors. Yes, for doctors, first thing is always scene safety, but there's no logo mentioned for the same. Okay. Which of the following is not a feature of Pancoast tumor? I will be drawing a line diagram showing the Pancoast tumor. This is the vertebra. You can see the two lungs here. Then I've shown the sympathetic chain. This is the paravertebral sympathetic chain. These are the ganglia of the sympathetic chain. And I'm showing this is clavicle. This is the clavicle bone. This is the clavicle bone. I'm showing a patient who's having a lung cancer and the cancer is increasing in size. And this cancer can involve the sympathetic chain. It can put direct pressure. This is the cancer which is increasing in size. It will put pressure on the sympathetic chain. So it will cause Pancoast tumor in a patient. Yeah. Please comment here, guys. Pancoast tumor is a adenocarcinoma, which is putting pressure on the sympathetic chain. And he will ask you, what will you do in this particular case? So the logic is that when you press on the sympathetic chain, it will cause perfect meal, Punjabi meal. So there would be ptosis. You know, the mnemonic is perfect meal. You want to call it Punjabi meal, you want to call it perfect meal. I'm okay with it. Perfect meal is for ptosis due to paralysis of the Muller's muscle. There is meiosis, that is for the M component here, enophthalmos, anhidrosis, and loss of ciliospinal fluid. We don't have a exophthalmos. Exophthalmos is what we get with respect to Graves' disease in a patient. At the moment, it is a enophthalmos that would be present. So the correct answer for the current question that I'm describing before you is option number A. Yeah, L is that loss of ciliospinal reflex. Okay. We sorted for 25. The answer is option number A. We move to 26. Chauvistok sign is a feature of. Yes, guys, a very easy question. Chauvistok sign implies that this particular guy would be having a calcium deficiency. This is the feature that is seen in option number A, hypocalcemia. The main point is you will tap on the anterior border. That is circumolar muscle contraction would be seen in this patient. In Trousseau sign, you have a carpopedal spasm. In Trousseau sign, you have a carpopedal spasm, but in this one, yeah, no, it's not trousier. It is वो spelling में mistake हो गया आपसे थोड़ा सा. Trousseau sign. In Trousseau sign, you will be putting a BP cuff in the arm of the patient, and when you put the BP cuff in the arm, it will cause. If you put a BP cuff in the arm of the patient, it will cause irritability of the median nerve that will cause carpopedal spasm as a manifestation here. Yeah, scenario is thyroid surgery only, as Avani is picking up correctly, but Rossio sign would be a carpopedal spasm, and Chauvistok is that circumoral. C से याद करना, circumoral muscle contraction. Chauvistok sign is C, circumoral muscle contraction because of the irritation. It is circumoral muscle contraction that is occurring due to specifically, the irritability of the facial nerve seen after thyroid surgery, you right. 26 is A. Let's move to 27. Again, a PYQ. Patient with TB and AIDS is started on antiretroviral therapy. He reports worsening of his symptoms with fever and malaise. Which of the following is the likely cause in this case? So the moment he's saying the word like TB and AIDS in a patient and worsening of symptoms, you are talking about iris immune reconstitution inflammatory syndrome, very typical for always AIDS questions. That is a paradoxical immune reaction. So this is again an easy one to be picked up. Yes, the answer in this question is A. No, drug interaction between ATT and ART would contribute to like jaundice, or they would be maybe development of any organ failure, but like this is worsening of symptoms of TB, that is immune reconstitution inflammatory syndrome, very classical कि ATT पहले चालू करना है, फिर TB का दवाई जो है पहले चालू करना है, फिर ART देना, gap should be 2 to 4 weeks. First answer is 2 weeks, and if I do opposite, that is when the problems would be occurring. So answer to 27 is option number A. This is a funny question. A wave in the JVP is due to, the answer is atrial contraction, pretty straightforward. Atrial relaxation will cause X descent. Ventricular contraction, okay, atrial relaxation and ventricular contraction both mean the same now. The answer is A. Atrial relaxation and ventricular contraction both mean the same only. Both mean the same only. So X only. And ventricular relaxation will cause a wide descent in a patient. Now we will practice those questions that say steep X and steep Y. Then we will practice steep X and absent Y. Then we will practice absent X and steep Y. Please hit the comment box, guys. Set the comment box on fire at the moment. Steep X and steep Y. Steep X and steep Y. This is the feature that is seen in constrictive pericarditis. If I say steep X and absent Y, this would be cardiac tamponade. Keep hitting the comment button, guys. Steep X and absent Y. That is cardiac tamponade. Absent Y. Filling in yoga. Very good, Ayush. Great. And if I say the word absent X and steep Y, then absent X and steep Y is a feature of tricuspid regurgitation. 3 must know MCQs for today, guys. 3 must know MCQs for today. Steep X and steep Y, steep X and absent Y, and absent X and a steep Y are standard features along with A wave in the JVP. And yes, I got good comments for tricuspid regurgitation as well. Let's move on to 29th here. Diabetic patient presents with pedal edema and shortness of breath due to heart failure. Which of the following drugs will be showing cardiorenal benefit? The word is cardiorenal benefit. Yes, guys. When I say the word cardiorenal benefit, then it's always gliflozin that would be present. If we will say which drug will reduce HbA1c, then answer is obviously, like, if the question says which drug will reduce HbA1c, then you have to answer it as insulin. But if it says cardiorenal benefit, then your answer would always be given as SGLT2 inhibitors that would be used in this patient. Canagliflozin or empagliflozin has a cardiorenal benefit that we are usually gonna exploit in our case. Highlight the state अगर वो देता है इसमें HbA1c 12% है, and how will you bring down the HbA1c of the patient? Then don't answer SGLT2 inhibitor, then answer would be given as insulin for the patient. Answer 29 is option number A. Let's move to the 30th one. 35-year-old female with history of rheumatic heart disease with mitral stenosis presents with irregular pulse. Again, irregular pulse is something that you have to remember always. It's a feature of atrial fibrillation. इसके लिए तो ECG देखने का भी जरूरत नहीं है. Though you can see here that the chap is having absence of P waves, no P waves present here, and there is the variable RR interval. The distance between these two areas, if you check out the distance between this area and the one marked in yellow, is totally having a disparity. I'll just do this once again. I mean, if you check out this area versus the one that I'm marking now with the following color yellow, you can notice the disparity that is coming up here. The disparity is the variable RR interval that is present, and along with variable there is the absence of the P wave. So the strategy for this patient would be to start this chap on yes, guys, you guys can help me out. Which medicine would be recommended for this patient? Rheumatic heart disease patient. The word is rheumatic heart disease, no? Yeah, race is okay, but I need to give warfarin to the patient ना. ACE inhibitor जब भी जब भी patient rheumatic heart disease का होता है तो warfarin देते हैं. If it is non-valvular atrial fibrillation, for non-valvular atrial fibrillation, you shall be using primarily dabigatran and rivaroxaban. But for valvular atrial fibrillation, because he has mentioned the word rheumatic heart disease, for valvular rheumatic heart disease, it is warfarin that would be used. Okay. Patient had a road traffic accident and fracture of the ribs. After 48 hours, he's having breathing difficulty. Yes, guys, this you guys can help me out. Fracture of the ribs. And then after 48 hours, breathing difficulty. Yes, this is not fat embolism. This is not fat embolism. You can notice bilateral, pura X-ray white ho gaya. And fracture of the ribs hai. The chap is having what is called as pulmonary contusion. When you read the causes of acute respiratory distress, the fractured ribs will also contribute to injury to the lungs. So there's a pulmonary contusion, and that will cause a non-cardiogenic pulmonary edema, that is acute respiratory distress syndrome. Fat embolism में जो X-ray होता है, उसमें most of the time that snowstorm appearance can be present, but it will not be so extensively wide as that of acute respiratory distress syndrome. Here the word is bilateral infiltrates. I mean, earlier also when I showed ARDS, I tried to increase the severity by showing it white here. That would be extensive bilateral infiltrates in acute respiratory distress syndrome. But when it comes to fat embolism, it is that snowstorm appearance, that white small dots that can be present here, so that can help in identify. Yeah, Nikhil, you had a good point there, pulmonary washout. Okay, there's a question on pulmonary thromboembolism क्यों नहीं है? तो देखो pulmonary thromboembolism में तो आई थिंक एवरीबडी वुड एग्री कि जो क्लॉट होगा उससे रास्ता बंद हो जाएगा, एंड व्हेन द क्लॉट विल ऑक्सक्लूड दिस एरिया यू कांट सी द क्लॉट बट यू विल बी एबल टू सी दैट triangular wedge shaped opacity. The triangular wedge shaped opacity is what is called as Hampton hump. So why the answer is not option number D is that in pulmonary thromboembolism in the chest x-ray, what will you see? You will be seeing is a opacity in the lungs of the patient. This opacity in the lungs is basically what is called as a Hampton hump. The correct answer for this question is D. Answer to 31 is D option. I hope it's clear now, guys. I hope it's clear now. Right? Why the answer is not D is कि उसमें Hampton hump होता है. That is like a obstruction. You can't see the clot on an X-ray, no, but you can see the pulmonary infarction that is present. Okay, patient is admitted with the serum calcium of 14. What is the best treatment for this particular case? So hypercalcemic crisis is what is asking here. This is asked in all exams. Nursing exam में पूछा है यार आजकल तो कि hypercalcemic crisis में क्या करोगे? So it is best treatment for this patient. Okay, so if he says the word best, then the answer is C. And if he says what is the first line management for this patient, then answer is normal saline. So if the question said what is best, then it is bisphosphonates. If it says first line, the answer would be given as A. Yeah, the only reason why I have not given option as A is because it is first line treatment. Best जो होता है वो पहले बिस्फॉस्फोनेट देके कैल्शियम का वैल्यू कम, सलाइन से तो देखो टेम्परेरी है ना, कुछ आवर्स के लिए कैल्शियम लेस करोगे, इट्स नॉट गोना कॉज कैल्शियम टू गो एनीवेयर. It will remain in the blood only, but bisphosphonates will send calcium into the bones. The advantage is bisphosphonates will send calcium into, bisphosphonates will be sending calcium into the bones, which is why the answer in the question would be as I've highlighted. 15-year-old boy presents with pedal edema, red color discoloration of the urinary oliguria, classical presentation of post streptococcal glomerulonephritis, because there is RBCs which are present here, 100 RBCs per high power field, so there is a hematuria. Along with hematuria, you can also notice there is a hypertension that is present. The BP is 110 by 160 by 100. Proteinuria is also present in nephritic syndrome. Nephrotic में तो होता ही है, but it is also present in patients who are suffering from nephritic. So this would be subnephrotic proteinuria. That is a proteinuria of 2+, and that means the answer in this question is post-infectious glomerulonephritis, PIGN. Okay, answer to 33 is option number A. Gross hematuria, macroscopic hematuria. Yes, that's the word to be used here, gross hematuria. In fact, I'll modify that. Not exactly gross, because he's mentioned microscopic here only. Na? He's not mentioned like very significant, I'd say smoky urine. You know, gross hematuria is if I said smoky urine in a patient. So here it will be standard that 100 RBCs to microscopic in. Berger versus Berger, you see the difference is Berger is thromboangiitis obliterans. Na? So there would be intermittent claudication occurring in a patient. Patient is a cigarette smoker. Cigarette पिएगा तब उसको चलेगा तो legs में pain होगा. So here he will always talk about calf pain and leg pain in a patient. Berger disease is immunoglobulin A nephropathy. That is option B. Berger's disease will always present with यहाँ पे it is like microscopic hematuria, which in 48 hours after a URTI, this person was having microscopic hematuria. इसको खांसी जुकाम हुआ. There was like a respiratory tract infection, and then this person will upgrade into gross hematuria. Okay, so I am getting this comment of cricentric glomerulonephritis. Okay, I'll come to that also. Berger's disease is microscopic hematuria, then moving on to gross hematuria. Now, why it is not cricentric glomerulonephritis? Because cricentric is usually more common in adult population, and cricentric glomerulonephritis usually causes a progression to chronic kidney disease. PSTN usually has a good prognosis. Considering boy 15 years of age, I'll go in favor of post-infectious glomerulonephritis for this patient. Okay, even RPGN is same as cricentric only, na? But that's like a bad prognosis and is usually seen with respect to adult population. The correct answer for this question is option number A.